We've been very focused on the liver for obvious reasons, but let's take a step back. And if you look at the causes of death in the United States, you see over here that the great majority from diabetes, cardiac cancer, even maybe strokes, that's a huge chunk of the death pie, if you will. And these, of course, you recognize are common risk factors that are present in the population that we're interested in, that is people with fatty liver disease. How do you get it to advance?
You have to press on the plus.
That's what I did. Okay. So, of course, you know, the cardiovascular and the diabetes field, because of the huge impact on population mortality, has been focused on studying this and evaluating risk for a long time. So if you go talk to a cardiologist, they'll tell you not only that you need to look at lipid profile, if they're a little bit sophisticated, they'll tell you, well, you really need to look at small density LDL, you got to look at the HDL class, you got to look at ApoB, ApoE, various genotypes, inflammatory markers, vitamin D, homocysteine, and this is just a partial list. And then you talk to the imaging guys, they'll say, well, that's all great, but you really need a coronary calcium score. Or if you're an ultrasound guy, if you're a CT guy, you want a coronary calcium score. If you're an ultrasound guy, you want to look at carotid intimal thickness. And then if you're a primary care physician or someone interested in diabetes, you're going to look at A1C, a lot of interest in beta cell mass and beta cell function. There's a whole FNIH beta cell project going on, markers of insulin resistance, and then, of course, you want to look at all the end organs. So lots to do already to tackle these major causes of morbidity in the general population. But here's who we're talking about. And if you're this person, I'm stuck again. Yeah, there you go. So Monday, he goes to see his PCP and gets blood work. Next day, he gets some imaging, and maybe we throw liver and heart together. But that's really probably a full, if any of you have ever been to a radiology department, that's pretty much your whole day if you're getting two separate types of tests done. On Wednesday, he goes to get his eye exam, another half day gone. Thursday, he goes for his peripheral vascular exam. Friday, you know, he goes to see his nutritionist. Saturday and Sunday, he's passed out. So that's the problem. The way we're approaching this is very segmented and siloed. And we are in the process of looking at our organ of interest, creating management paradigms that are incredibly burdensome for the patient, incredibly expensive for third-party payers, and maybe not as effective in the end as they could be. Can I have the next slide, please? So what is needed is a more integrated approach. And when Veronica and I were planning this meeting, we thought this would be a good place to stop so that it's food for thought for everybody to think. Not that I have any real answers to give you, but more to frame the question that maybe we should think about things a little bit differently. We need to be able to predict risk or diagnose based on context of use, and ideally something along a continuous scale with a good dynamic range. We need to be able to integrate the principal risks at the individual patient level. We need to be able to define when to do the test, how soon to repeat, how to interpret it, and these have to be linked to a decision to treat because they have to be actionable results. Otherwise, you're just doing it to satisfy your curiosity, and that's never a good reason to do anything. So next, I can use the mouse now? Okay, cool. So when you think about potential opportunities in our population of interest, one could think about assessment of risk very early in life, some primary preventive approaches if we knew who was really at risk, because right now we can't really engage other than telling people to live a healthy life. We really don't have any focus strategies in terms of primary prevention because we have no idea how to get around this question. Then when you have the person who has the disease, we have to diagnose, we have to prognosticate, to identify who needs more aggressive intervention, develop what intervention, and then to figure out if they're responding to the intervention. So at each of these steps, in the appropriate context of use, there's a set of questions related to biomarkers that come up. And so while we've been talking about biomarkers sort of in a generic vanilla fashion, the reality is if you really want to be serious about this and develop biomarkers that will eventually have a role in the management of patients on a day-to-day basis, you have to focus your scientific questions very narrowly and answer those questions so that as a clinician, I actually have a real answer to the question I'm interested in, which is a very focused question along this pathway over here. So let's start at the top. If you talk about assessment of risk, this could include both clinical and laboratory parameters. This is where I think genetics probably could play a really important role, because here you could stratify based on risk of maternal obesity, diabetes, family history of diabetes, heart disease, and all of these things, and integrate these with genetics. We already have talked about NASH-related genes, and even though we don't really understand them very well yet, but maybe we will soon. But we also know that there are SNPs that are associated with metabolic syndrome and diabetes. And John Snitsky, who's going to follow my talk, actually published long before at least I was thinking about these type of things, a panel of SNPs related to fibrosis. So if we can combine those approaches, there may be sort of a genetic profile that could emerge that would tell who would, if given a metabolic stress test, if you will, by calorically overloading them, is likely to develop a much more florid and aggressive disease phenotype. So that's sort of work to be done. Something we never talk about because we don't do it very well and we therefore try to act like it doesn't exist is the issue of behavior. This is a disease that has behavior as a fundamental underpinning of the disease. Behavior is determined by not just genetics. Genetics may be important for behavior, but there are economic, social, cultural, political, all kinds of issues. And behavior is important because behavior determines the kind of lifestyle choices you make or are able to make. If you live in one of the really poor parts of town and have no access to healthy foods, you can't really expect them to give them all these nice little charts and tell them they should be taking 2 of this and 4 of that. Doesn't work. Compliance, motivation, and their ability to change behavior and are all impacted by behavior. And so if we are going to be serious about lifestyle, I think if you assume behavior as another biomarker of what's going to happen to the patient, this is really a major unmet need, in my view, in the field. And I think hepatologists have been really behind in terms of acknowledging and taking this on. So we didn't do a great job with early identification. So here we are sitting in our clinic, and here comes the patient. And this is very similar to Brent's patient. So we come full circle now. So this is, the patient's got a little bit of a pot over here. Fasting blood sugar is getting up there into the hundreds. AST/ALT, not that dramatic, but by the new thresholds, probably elevated. And they've got a little bit of dyslipidemia going on over here. So what do you do with this person? So again, you don't want to, what I've outlined is our current approach is you do the battery of tests for cardiovascular, battery of things for the diabetes. We want to assess the beta cell thing, and then we want to assess their NASH and their liver and their eye, and by that time, the patient and their doctor both go mad. So we need to define the specific context of use. I think one potential approach could be to really focus back on the biology that connects diabetes, cardiovascular disease, and fatty liver disease. And if you can identify common biological pathways linking fatty liver disease to these other conditions, and then search various things that we can actually measure, and this is just a partial list, it's not meant to be complete by any means, and can link them back to these common biological pathways, and then be able to link those parameters to the actual manifestation of the disease and clinical outcomes, then we have an integrated approach that takes care of all 3 while reducing the burden of blood work and testing for the patient. So let's talk about what these pathways could be. So here's some observations for you. If you look at atherosclerosis, what do you see here? You see fat, you see inflammatory cells, and you see some scarring. So it's a fibro-inflammatory atherosclerotic plaque which contains excess lipid. So 3 things: fat, inflammation, and scarring. And indeed, it's linked to fat, inflammation, scarring elsewhere. So this is a population-based study that we published some years ago. Shadab, if he's still here, was the first author. And we show that the liver fat score actually correlates very tightly, fairly nicely with percent small density LDL. We also showed in a more focused study that if you look at the desmosterol to total cholesterol ratio in circulating blood, and this is a validated marker of cholesterol synthesis in the liver, it is increased in patients with NASH. The cytosterol, which is really a marker of how much cholesterol you're absorbing from your diet, really is not that different, but clearly in our patients with NASH, despite accumulation of cholesterol in their liver, they have increased cholesterol synthesis going on. So this is something you can measure in blood. Now, when you combine that to inflammation and you plot the CRP and the LPPLA2 tertiles, you see over here again that the more inflammatory markers you have, the more likely you are to actually have a clinical cardiovascular event. So fat, inflammation. What about fibrosis? This is, of course, based from our animal data because it's hard to get myocardial tissue for studies from humans. But you can see that in the diamond mouse, over time, there's progressive steatosis, whereas in a normal mouse, you see this very beautiful Z line and nice actin-myosin fibrils. In the diamond mouse, it becomes raggedy, and you start accumulating in the small vessels. These are megakaryocytes and platelet accumulations and microthrombi. So this tells you what is happening. So you get the fibrosis, you got the inflammation, and you got fat. And indeed, if you look at at a molecular level, you have oxidative stress, you got markers of ER stress. Well, what a surprise. These are the same things that we see in NASH, because you see the changes in lipid metabolism, you see oxidative stress, you see ER stress, you see activation of inflammatory pathways, and then fibrosis eventually culminating in cirrhosis. And if you actually do a transcriptomic analysis in humans who have progressive disease, this is a data that we just presented at EASL. It's a cross-sectional analysis of people, of 84 patients with full spectrum of disease. But if you look at those with advanced fibrosis, with early fibrosis, advanced disease versus early disease, look what pops up here. ER stress, FXR signaling, oxidative phosphorylation, more oxidative stress, and again over here, connecting ER stress to inflammation and then mitochondrial dysfunction. So again, you're beginning to see some common themes beginning to emerge. If you look at adipose tissue in these same patients, you get these crown-like lesions. This is again a picture that Pierre shared with us, based on our diamond mouse model. And now there's emerging evidence that you even get fat in the pancreas. And there are non-invasive tools, and this is actually a pancreatic fat map done by MR. And because we heard a lot about doing this in the liver, but now you can do it in other organs as well. And so you could potentially think about a comprehensive fat map. Now, if you then think about, I've showed you 3 different conditions, diabetes, cardiovascular, and liver, all having fat, inflammation, cell stress, and fibrosis. So if you take that back and start thinking about what the readout of that could be in circulation, blood, spit, urine, whatever, your bodily secretion of choice, you start seeing that people have already been thinking. I thought I had hit upon this, and this was a great novel concept. But Marjorie Connolly shared this with me, and this is the LabCorp profile. And so this is called the Diabetes Risk Index to predict who's going to get diabetes. So as you go through over here through insulin resistance, and your fasting blood glucose gets above 100, 120 over here, you have these lipoprotein changes as early markers. There's an amino acid signature that occurs later, and then this inflammatory marker, and this relates to beta cell dysfunction. So if you actually look at all of these together, what you find over here is that by combining these, you get a diabetes risk score, which predicts the risk of progressing to diabetes and can stratify the risk of patients most in need of aggressive preventive therapeutics. Well, you said, great. Is there any real data that you're going to show me that it works? Well, here's real data from the MESA and the IRIS study, which shows that above blood glucose and BMI, when you add the diabetes risk index, you start predicting, and with pretty reasonable AUCs over here, you start predicting risk of actually developing type 2 diabetes. Now, how can we then combine that and make it predict what's going to happen in the liver? So here's some data that nobody else has seen yet. And this relates to patients who were in the flint trial. And we got this diabetes risk index score as part of a larger lipid analysis we were doing. So we looked at even within patients with NASH. If you look at before and after, what we see over here is that there's a linkage with histological scores over here. Now, of course, there's a mix of patients before and after, so this needs to be cleaned up a lot. But the point I'm trying to make is, if we can find a consolidated set of things that are linked to the common biology of steatosis, inflammation, and fibrosis, that can then be linked back to diabetes, cardiovascular disease, and liver disease, that would make it a lot easier for the patient. And in fact, you see over here, these are again early data, you can see that the left ventricular end diastolic volume in patients with NASH is decreased compared to fatty liver and matched controls. So potentially, what I'm trying to suggest is, if we look at the biology of the disease, and there may be other elements of biology that are not here, but I'm focusing mainly on metabolism, inflammation, and fibrosis, if we can find a signature that tells us, is disease present, how bad is it, and what is the prognosis, and link it back, ask these three questions in terms of heart disease, diabetes, and fatty liver disease. If we can find some common elements, then I think we've made some real progress in the field. So in thinking about how to integrate all of this and use it in the future, you could think at birth, you do a bunch of genetic testing and family history type stuff, and come up with a profile risk stratification. And people who are at high risk, those parents should be counseled about best practices for their children. Maybe another set of profiling, pre-puberty. Why pre-puberty? That's because at that point, your end organs are probably still intact. And it gives us an opportunity to intervene before you have blown your end organs. Once you have hypertension and hardened arteries, then doing all these drug therapies just doesn't make any sense to me intellectually. I know you have to do it. And then maybe sometime, once they get through puberty and get through college and get all their craziness out of the way and settle down in life, then maybe there should be an assessment at that. Well, it's real life, So then you reassess and see, when people settle down, have a family, they're beginning their real life, then you reassess. And this may be a time where you should do the first time, you should also check some end organ, the status of your end organs, because some people will have end organ injury, as we are finding out by this time. And then eventually, maybe at age 40, if they continue to remain asymptomatic, do that one more time, because most of the outcomes will occur after the age of 40, or at least in 2017, what we see based on large data sets is that the real hard outcomes usually occur after the age of 40. So I'll leave you with those thoughts, not necessarily that I've given you some major clue as to how to fix the problem, but things to think about and chew on, that maybe everybody has a different way. This is incredible amount of innovation. What I want to do is frame the question and leave the door open for any kind of innovation. So, right now what we're doing is ordering batteries of tests, and that's probably not the greatest thing. And of course, I'll finish with this quote: predictions very difficult, especially about the future. So I made some predictions about the future. They may or may not be right. Thank you.
Thank you.